Hi guys, my name is Zoe. I'm going to be presenting with Cal. We are going to be presenting on Module 3 and the case study that we came up with. Okay, so first we're going to be talking about the trans-theoretical model of intentional behavior change. So the TTM offers an integrative framework for understanding and intervening with human intentional behavior change. There are 4 dimensions in the TTM, which involve stages of change, process of change, markers of change, and then the context of change. Okay, so we're first going to talk about the pre-contemplation stage. The TTM is a multidimensional and nonlinear model. So while going through that, just think that it's not going to be a full cyclical process. The pre-contemplation stage is when the individual is currently satisfied with, or at least unwilling to disrupt, a current behavior pattern. Which then if it moves to the contemplation period, this is usually unstable. It's where an individual could be struggling to leave one pattern of behavior to another, but at least they are willing to disrupt that current behavior pattern at that time. Moving on into the preparation stage. This is the stage of organizing the environment to even make it possible for the action to happen. It's making it conducive for the change in habits. Moving on to the action, it's the implementation of the plan. It's the first step in changing and making new habit pathways and breaking old pathways of behavior. The time frame of this usually takes 3 to 6 months to actively change old behaviors and replace them with new ones. The maintenance is the integration of the new habits into the lifestyle, making the effort become an automatic system of function. This whole process is not as smooth as it looks. Like I said before, it's nonlinear. It could have regressions, recycling, and progression all over again. It's chaotic instead of the depiction of a perfect spiral, and it takes repetition and some major commitment on the individual's part. Okay, so now we're going to look at the traditional models for understanding addiction. These look both into internal and external factors that contribute and lead to the continual use of substances. So we're first going to talk about the social environmental models. These explore the role of social influences like peer pressure, the accessibility of the substance, the social and familial systems that are involved, and then these are just kind of the external factors contributing to the addiction that I was talking about. And then going into the genetic, it talks about how it is not one specific alcoholism gene that can be pinpointed to the reason for alcoholism and addiction. It is, in a sense, polygenic and complex. This is meaning that it could be influenced by 2 or more genes, making the inability to pinpoint it. Tolerance and the need for more of the substance to reach the same effect is also considered in this model. It talks about the neuroadaptations and the drug dependence, which is both behavioral and tied into brain components. The personality and intrapsychic models talk about some pre-alcoholic personality that are prevalent. Some of these could be impulsivity, nonconformity to social norms, antisocial behaviors, independence, and hyperactivity. According to psychoanalytic perspectives like Freud, some have characterized both alcoholics and persons with eating disorders as individuals who have had conflicts at the oral stage of the psychosexual development and were fixated at this stage specifically. So then going into the coping and social learning model, This is the model that states that addictions often stem from poor coping and self regulating habits. This is where you may turn to alcohol or a certain substance for an escape or for comfort during very varying life stressors. And then moving on, another one that's really another model that the chapter talks about is the conditioning and reinforcement models. This section focuses on pleasurable effects that drive the continued use for the substance. It talks about the direct effects leading into the reinforcement, like withdrawal and, you know, the tolerance of needing more of that drug to get the same effect. The next one is the compulsive and excessive behavior model. So this one talks about how addiction is often linked to ritualistic practices. These compulsive and repetitive behaviors try and satisfy a psychological conflict and need, and often leads to an attachment of the behavior and not just over the substance itself. And then when talking about the biopsychosocial model, it looks at understanding addiction through a holistic lens, looking at the whole individual and their dynamics and systems that are involved in their life. This looks at the multiple causes, factors, and levels of causing the addiction.
Perfect. Thanks for covering the textbook content, Zoe. Now I'm going to jump into our case study. So our client, Emily Smith, is a heterosexual female, 32 years of age, with a 12-year-old son, divorce currently in progress, and she lives in a one-bedroom, one-bathroom apartment after splitting up with her partner. She's been a bartender for the past 5 years, and is still currently working as one and has no religious affiliation. She was referred to us after an ER visit for alcohol poisoning after a particularly rough shift. And as always, confidentiality, informed consent, and the release of information were explained, signed, and discussed. So as I mentioned earlier, our presenting problem is our client showed up to the ER with alcohol poisoning. The client was then referred to an inpatient detox, White Sage, down south, and did a 4-day detox for alcohol withdrawal, and returned to their apartment. They're currently going through a divorce and had to move out due to their use. They are sharing custody of the child, but their partner is the primary custodian, and she only gets to see her son every other weekend at the moment. So she does have a history of the presenting problem. The client originally started abusing alcohol due to her work environment, high stress environment, very common to see alcohol use disorder in the bartending industry, and she's had many major life stressors over the past few years. She also suffers with major depressive disorder, which kind of pushed her into binge drinking on the weekends, which eventually escalated to daily use, drinking on the job, etc. The daily use started about a year ago, and currently she has been completely clean and sober for about a month. And to jump into the next part of the BPS, so in terms of substance use history, our client started with cigarettes, age 15, just occasionally smoking them. But daily use started at 29, about half a pack to a pack a day, and she is currently still there. Alcohol, again, occasional use started young, around 16. Binge drinking started around age 29. That's going to be about 8 drinks per night on the weekends. And then at 31, she started drinking daily, 10 to 20 drinks a day, before work, during work, at work, etc. And she has not had a drink in 34 days. She had to be admitted to an inpatient detox for alcohol withdrawals due to the severity of her condition. She has also been smoking marijuana occasionally since age 17. She is a medical marijuana patient and smokes daily. She has not smoked in 34 days since the ER visit and did not need a detox. She does report feeling a bit more emotionally volatile, irritable since quitting, but otherwise not experiencing any physical withdrawal symptoms. Um, and she also occasionally used stimulants, including dexedrine or dextroamphetamine and cocaine, kind of to stay up, get right on nights at work where she drank too much. Occasional use started at 31 when she was working at the bar, at most 3 to 5 times per month with the dexedrine, she said 15 to 30 milligrams per dose. And she has not taken any in about 2 months. Did not need to detox, is not a daily user. Cocaine, similar story, occasional use starting at 31 once the binge drinking kind of picked up. Maybe 3 to 5 times per month. If she does it, she does a whole gram in the night. She has not used cocaine since the day that she got alcohol poisoning, and again, did not need a detox because she was not a daily user. Now on to mental health history. She was diagnosed with alcohol use disorder. After her screener results, we administered the DAST. She scored an 18, and anything over 12 is considered alcohol use disorder. Additionally, she was diagnosed with major depressive disorder at 18 and attended private one-on-one therapy until the age of 21 when she felt like she could manage it on her own and did not need help. And as previously mentioned, she went to White Sage Recovery for an alcohol detox after the ER. She has left detox as of 30 days ago. Now, the community resources I recommended for Emily, I wanted to start with some sort of outpatient recovery program so she could continue to work while also getting the treatment that she needs for her AUD and her MDD. Additionally, I found a recently divorced group at a counseling center. This can really help her find a more healthy community outside of work, get some support, and learn how to get back into her child's life in a meaningful way again. And then finally, I referred her to Ascend Staffing Agency, a temp agency down by where she lives, that can hopefully place her with a better job. So she's working in an environment with less risk factors because bartending is a very hard job for somebody who's trying to stay sober. And then our references are just the textbook, Addiction and Change, as well as the NASW Code of Ethics, as always. Thank you guys for watching.
Thanks.